o'clock, and I'm John Spurtis, and I just want to thank everybody for coming to the QVIC forum. And we are really excited about today's presentation. We've got some extraordinarily talented speakers from around the country of sort of national and international acclaim. And I have the privilege of orienting everybody and opening up the forum today. And I'm John Spurtis. I'm a professor at UMKC, and I've been working on developing the QVIC, which is, really an effort to bring multiple stakeholders, patients, payers, purchasers, researchers, providers, community-based organizations together to think about new and novel strategies to improve the quality and value of healthcare in Kansas City. And I have the privilege of working with Christina Pacheco and Stacy Farr in leading this effort. And, what we're really trying to do is to share and to bring different ideas together to think about how we can accelerate the translation of new knowledge to practice and to support our hospitals in sort of evolving from the concept of a learning healthcare system to a learning healthcare community. And that's what we've been working very hard to do. And towards that end, we keep at the center, obviously, patients and the populations we serve in our region, but we're trying very hard to improve the quality of care, to lower the costs of care, while also improving the outcomes of our patients. And the way that we have sought to accomplish this through the QVIC is to really have three major foci of activities. One is around regional quality improvement projects. And towards that end, we have engaged, as you can see, 8 different hospitals in a Missouri-based opioid, dealing with opioid crises in the ED, and you've heard about this in the past. And the other is that we have 13 hospitals now, although only 11 are listed, that are starting to collaborate on our transitions of care, which is very relevant to today. I won't be talking about this program today, but very relevant to today's discussion, thinking about how we reduce readmissions. And we have a broad array of interventions that we're offering and supporting to help do this. And we have had all of this really on hold pending the COVID pandemic, with the intent to sort of relaunch with the vigor of these efforts in July of this year. We've also been able to supplement the quality improvement projects with training programs, the Tiara program, trying to give a very practical overview to both academics and to the health systems that we work with in what implementation and dissemination research is. And we'll be continuing to sort of rethink how to expand and do Tiara 2.0 over the next year or so. But the other sort of the third leg upon which this stool stands is this activity, which you are all part of today, which is the forum. And, these are opportunities for multiple people, anywhere from 20 to 80 people have attended these seminars, to be able to sort of talk about timely issues that are confronting healthcare in our region. And today, as you all know, is about reducing readmissions as a component of value-based care. This has been a thorny, a complicated, and difficult issue, both with people having different views about the value of this as a goal, and also with the challenges in the strategies to actually achieve that goal. Next month, we're having a forum on isms, phobias, and microaggressions in healthcare, and then strategies for healthcare provider, changing provider behavior, which is very challenging. And so you'll continue to see, and you're on the list, which is how you got invited today, that we'll continue to have a very, I think, robust educational platform for broad discussion. And towards that end, today, I'm really excited about this presentation. We have always sought in these presentations to have different perspectives, those of providers, those of payers, those of researchers, et cetera. And, we have such good speakers today that we actually are only having 4 presentations. And the first, if he is here, will be Tony Sun, who is the Regional Chief Medical Officer and Senior Medical Director at United Healthcare, who will be talking as a payer about how they're thinking about bundles and value-based care payments. He's going to be followed by Karen Joint Maddox, who is someone I've known since she was a trainee and am just in awe of her talent and skills and perspective. And she's got a very storied background in working with Medicare and having the insights of big data and economics to think about a lot of these kinds of issues, such as how we could create new payment models that could help support higher value healthcare and reduce readmissions. We're very fortunate to follow her with a very sort of practical strategy insight from Colleen Booz-Dietrich, who leads the work at KU Medical Center, thinking about the frequently admitted patients and how to directly address that person. And then after her, we'll have a researcher perspective from Harlan Krumholz, who again is, one of my oldest and dearest friends, who will be talking about sort of post-hospital syndrome, really thinking about, how the hospital experience might be contributing to readmission, because we on the research side have to realize we haven't yet figured out how to really alter this. And then Christina Pacheco will be leading the discussion afterwards. And so with that, I would really like to introduce Tony Sun, who will be discussing his view and perspective on how innovative bundles and value-based care payments might help improve the value of healthcare. So Tony, I turn it over to you.
Hey, good afternoon. Can you all hear me okay?
We sure can, thank you.
Wonderful. I wasn't sure if I get to drive the slides or you guys gonna do that. Either way is okay.
If you're comfortable sharing your screen, I think it'd be easier and more natural for you to do it, but I'm not sure that I have your slides, so I could probably—
Not a problem. Give me just a second. I'll open that right up. Well, first of all, thank you all for inviting me to have this great discussion with you all. And as you will see, much of my discussion is based on really some of the United Healthcare experience. However, you can certainly apply this to many other payers. I'm a little biased in regards to, obviously, from UHC's point of view, but I would hope that you all can do the similar things in applying it from various other payers. Let me know when you can see it.
We do not see them yet. Do you want me to see if I can find them and share them?
No, here we go. How about now?
Perfect, thank you.
And I'll put it on the slide view, okay? So if you think about where United Healthcare is going in regards to value-based care, it has been rooted into the work that they've been doing, okay? So it's not anything particularly new from their perspective. Much of this work actually has some academic backings in regards to a work that they jointly done with the Harvard School of Public Health and so-called the 3D model, okay? And I'll be happy to share that white paper with many of you. And it's too many of us, it's probably very given, but I want to make sure that it is very sound on how we go about doing this work. It took them a little time to kind of get going, probably in the early, probably 2010s and 2015s, when we were just beginning to get really sort of invested into so-called value-based care and the whole, I call it the march toward the ACOs or accountable care organizations. I think of this also as a spectrum of a continuum value-based care in which I'm going to share with you. So this whole 3D model is really based on three dimensions, okay? One is how do we design quality incentives to help providers to move toward value? How do we then utilize spending reduction to drive more value? And then third is infrastructure support. We need to have infrastructure support to help building toward that value. Okay, so with that said, you should be able to see this particular slide. So this is value-based care. If you think about on the bottom there is where we have been for so long is the volume fee for service. But then as we move much toward upstream in regards to performance-based, that's where we have measurements for pay for quality. And that's been rooted in many of our hospital contracts throughout the city, throughout the region, throughout the country. So that means we pay hospitals based on how well they're doing in reducing lengths of stay, balancing it with appropriate reductions of readmissions, hospital-acquired conditions reductions, also reducing, avoidable ED visits. These are paid for quality. They're usually tied to some sort of contracting escalators, may it be for a hospital, for a surgical group, or physician group. Those are what I call pay for quality. Then we have the bundle payment, where we have bundled much of the payments into a grouping, may it be a overall bundling. The most known in this space is probably, we pay transplant on a bundle payments. We are beginning to pay for other things, in which I'm going to dive a little bit deeper into on either musculoskeletal or cardiovasculars or maybe even medical conditions in that degree. And then last but not least is our accountable care programs. Our accountable care programs is what we think is the most fully integrated program in various degrees with either physicians group, health systems, or various other aggregation of providers on how do we manage populations, may it be for commercial populations, Medicare populations, Medicaid populations. So this is sort of that spectrum of what I spoke of. United actually takes really very conscientious decisions about where provider is and meeting provider where they are, okay? And so not just saying, here you go, Medicare Share Saving Program 1, that's the only model we have, that's how you go with it, and that's it. No, we actually go and assess and seeing where we think they are in this whole continuum of moving toward value, making sure that they really have not only the appropriate infrastructure as well as added infrastructure to help with that, in addition to our support. So oftentimes I usually say is that we take our time to make sure we are meeting at the right place, but once we get going, we want to make sure they perform. I call it the 6 pillars of success. Is really what we do is organization and accountable care organizations is really under these 6 pillars. One is really to improve on how we identify high-risk patient care, okay? These are people who are at risk of having heart failure exacerbations, having a bad outcome from pneumonias or other likely multi-chronic, polychronic conditions such as both diabetes as well as coronary artery disease, okay? And then we want to improve access to some of the care. Most important, improving access to front-end primary care instead of back-end emergency room visits, and worst of all, avoidable readmissions on the 3rd pillar, okay? And then if you look at the fifth one is how do we improve quality and coding? If there are things that people are doing, capturing those quality data and accurately coding some of those information, we want to make sure they get credit for doing those type of work. And then last but not least, it's really improving satisfaction, both at the member experience as well as the provider experience, as we have often talked about the quadruple aim. So I think most of this is very familiar to you guys, but I think it's good to, again, set this foundation for this discussion. If you think about some of the results we saw early on, and again, these are fairly outdated already. I know the fact that we're hitting way north of maybe closer to probably 10% for some of our ACOs, having fewer ER visits, much better quality measurement for some of our commercial ACOs, as well as fewer readmissions. But again, this is just a example of some of the outcomes that we're beginning all to see. But that takes tremendous provider-payer collaboration and integration. I often use the word I talk about is blurring the line between payers and providers. All right, so as I alluded to, we want to jump in to talk quite a bit about, can y'all see this? Is this too small? Should I show a different view?
Looks good on my end.
Yeah, we can see it fine, thank you.
Okay. All right. You guys are seeing the slide view, right? No. Okay. Perfect.
Yes.
So as you think about our bundle program, I want to highlight a few of them for you and give you a sort of an overview about our Medicare Advantage Care bundles. Similar to some of the fee-for-service CMS, their bundle payment processes, we have now embedded Medicare Advantage bundles for a total cost of care share savings program. So we set a target price that is created for our book of business on a retrospective bundle that's comparing a blended rate across all facilities. And the target price is based on historical claims in that regards, and then target price to bringing that down. Now, none of this could be done without that discussion with the providers in regards to meeting the quality matrix. Quality is foremost a gateway for us, and then we want to offer a sort of full support service. Again, remember that 3 Ds I talked about. We want to do quality, we want to make sure we reduce appropriate reductions in cost, but also providing us support. That flexible service that we have with our data analytics and performance management in that regards. So what are we talking about? We're talking about, on the surgical side, we have surgical bundles in those type, not all inpatients. We even have some outpatients now as we begin to work toward some of these surgical bundles that could be done in an outpatient basis. So cardiac valve, obviously, bypass, hip, knees, spinal fusions, as I said, even going toward outpatient on knees replacements. And then, of course, inpatient and outpatient PCIs. So that's the surgical bundles. Then we also have medical bundles that we're beginning to explore is on COPDs, heart failure. I think some of those we're going to be seeing quite a bit more, and sepsis and pneumonias and strokes. These are the so-called medical bundles that we're beginning to roll out. And then we want to have both a surgical and medical performance levers. What are some of those key levers that would help with this? Appropriate use of post-acute care after these procedures or medical are done is going to be critically important. How do we also, again, under one of our pillars on how to reduce avoidable ED visits in the post-discharge period, as well as readmissions. Every time I talk about EDs, avoidable EDs, think about also avoidable readmissions. And then helping them selecting, I call it a effective post-acute care provider, so-called a preferred provider network that has good outcomes and willing to work with hospitals in that type of post-acute care setting at the right price, and then prevention of some of these outlier admissions. So these features are set for our Medicare Advantage programs. There are options for downside risk, but most of the time we start the standard model with no risk, okay? And then reconciliation is going to be critically important on the annual basis, and then also some payment limits that we would set if there are, and we would want to make sure that we cap some of that at a percentage that would be volume weighted. And if you think about if there are people who are willing to go a little bit farther on downside risk, there is a letter of credit that needs to be required. And of course, meeting the quality matrix. You know, it's one thing to achieve the savings under the bundles, but we need to make sure that there's a gateway for the quality. So what is included in these bundled services, starting from admit to discharge? You know, we have stayed within a lockstep on sort of the exclusions as well, mirroring what CMS is doing in that regard. So for example, we want to make sure some of those really expensive drugs are excluded, okay? If a drug is dispensed through medical benefits. And then we want to make sure also some of the readmission exclusions, okay? In particularly if it's planned, and some of the more catastrophic admissions such as car accidents or transplants, et cetera, is appropriately aligned in that regards. We will have a payment appendix based on these bundle contractings, and most of those are very near to the CMS efforts.
Tony, we have about 3 more minutes, just as an FYI.
Oh, okay, great. All right. So thank you, John. So our efforts here within the bundle payment program, you probably are thinking like, okay, that's great for Medicare populations, and we're going to start our processes early in working with our MAs. But I just want to let you know we have already begun some of this discussion also with our commercial populations as well as our Medicaid populations. So we're testing that with some of our key provider partners. I'm happy to report that, you know, we have a great partnership with quite a few Kansas City as well as Kansas local providers on our Medicare bundled savings programs as well as ACOs. I'm happy to say that St. Luke's is one of our key partners in both a commercial and Medicare ACOs. We absolutely enjoy our partnership and relationship with many of these ACOs throughout our markets, so much so that, you know I work closely with various physician leaders in that regards. We're meeting with them on an ongoing basis, monthly basis, on how do we do that. Again, that infrastructure and support is important in our 3D model to help provider really to achieve the triple aim or quadruple aim in that regards. And again, within the 6 pillars we spoke of our ACOs, as well as these key areas within our Medicare Advantage bundle savings programs. Again, I'll try to save some time for other discussions as we move forward. I'll try to stay on for the Q&A session, and I'm definitely looking forward to hearing from all these great presenters as well. So thank you so much.
Thank you so very much, Tony. Really, really appreciate it. And It's going to be very interesting to learn more about how some of these programs that United's working on work, and what makes them more successful or less successful. The next presentation is going to be a policy perspective. And as I alluded to at the beginning of this, Karen Joy is really one of the rising rock stars in thinking creatively about how to design healthcare policy to optimize the quality and value of healthcare. And she comes from across the state at Washington University, where she co-directs the Center for Health Economics and Policy at the Institute for Public Health at Washington University. And she is a cardiologist colleague. And thank you very much for taking the time to share some of the things you've been working on and the ideas you have about how we can come up with new payment models to support higher value care.
Thank you so much for the kind introduction and for having me as part of this great panel. I hope you can all see the regular view and not the presenter view, but please let me know if you're seeing presenter view at this point.
Perfect.
Great. Onward then. So first, some quick disclosures. I did previous contract work with the government. I will not be speaking on behalf of them today. Have grant funding related to alternative payment models and serve on a health policy advisory council for Centene, which is a Medicaid managed care organization here in St. Louis. So I'm going to talk a little bit about readmissions and anchor it first around this patient. So this is a map, if you'll allow me to call that a map, of what we see so often in clinical medicine, which is this cycle of continuous admissions and readmissions, often punctuated by things like home health services, a readmission, going to a skilled nursing facility for rehabilitation, returning home, maybe being at home and doing okay for a little while, and then suffering an acute decompensation. And this is, mapped out here for heart failure, but could very well be many other chronic diseases that follow this same paradigm. Now, when we're thinking about how we want to break this cycle, when you're talking about readmissions, it's always a good idea to cite something by Harlan Krumholtz, who sort of invented this field. And one piece of the many parts of this puzzle that he has helped to fill in is understanding what some of the things that bring people back into the hospital are from a clinical standpoint. And so here you can see, looking at folks that came back in after a heart failure hospitalization, that the most common reason for readmission was heart failure. But I will point out that actually only about half of the reasons people came back into the hospital were cardiovascular. And so in fact, we see that renal disorders, pneumonia, sepsis, COPD, and the bucket complications of care all had really significant contributions to why people were coming back to the hospital. And so when we think about people who have heart failure, or again, really any other chronic disease, we do need to think about them as someone broader than only one condition. The other way that we need to think about people more broadly is in terms of their social risk. So we understand from other studies, and this is some work we did, again, looking at a heart failure cohort, that these findings are not dissimilar in other groups, demonstrating that individuals who are also covered by Medicaid, so those living in poverty, individuals who have a federally recognized disability, so get Medicare benefits in part because of disability, those with housing instability. So you can see in the bars in the middle that as you go up to the number of zip codes that someone reports essentially to Medicare, over the course of the study period was highly correlated with their readmission risk, whether or not they live in a high or low deprivation neighborhood in the next two bars, sort of the green and purple, I guess, and then whether the hospital is located in a deprived area. So all of these things clearly impact readmissions and clearly affect how we should think about what policy needs to focus on in order to reduce these adverse events. Now, when we think about how we'd want to do this with policy, I think it's worth thinking a little bit about the disconnect right now and how we think about it, right? So we have a patient going through a series of clinical events. We have then a series of people on the clinical side that are supposed to be interacting with that patient to try to figure out how to keep him or her out of the hospital. And it could be a cardiologist, it could be a home health nurse, it could be a hospitalist in a subsequent admission for sepsis. It could be a sniffist, so someone who specializes in providing care for people in a nursing facility. It could be a different home health agency and a different home health personnel, primary care, nephrology. All of these things are sort of circling around the patient. And right now we put a lot of the onus and policy on the hospital, which is that one little piece sort of up at the top there, the admission for heart failure, and often the cardiologist who may be associated with that admission. And I would argue that for policy to really start to change readmissions through value-based care, that we ought to recenter this conversation around the patient and think instead about how we can put value-based care in the outpatient setting, and certainly collaborate with the hospital and leverage hospital resources, but think more about if we backed up a little bit and said, if we're designing something new around patients, where would we start? And maybe we're at a point in time now that hospitals do have experience with value-based care, that payers are excited about value-based care, that we can start to think about this and redesign around the patient outside hospital walls. So if we think right now about sort of fragmentation, right, all of the places that patients have to go, and we have individual readmission reduction programs in each of these places, the hospital readmission reduction program, the skilled nursing facility readmission reduction program, we have the ACOs, and we have the outpatient MIPS, or merit-based incentive payment system, which are focused on the clinician. Each of these include readmissions. That creates some fragmentation, obviously, as people go from place to place, but at least everyone has some sort of common language. Sometimes we have duplication, particularly for patients who have a lot of chronic disease, where primary care and specialty care are sort of trying to co-manage, but not necessarily under the same payment model. But where we want to get is to focus all this around the patient. So some work that we did with the American Heart Association as part of the Value in Healthcare initiative started out with a simple patient survey. And we asked patients, what does value mean to you? If we were going to center something around you, and this is cardiovascular patients in general, though a big chunk had heart failure, what are the things that you might want us to incent? And of course, none of them said readmissions per se, though I think most people would be very, very glad to be out of the hospital. But people talked more broadly about some things that were really illuminating, I think. So obviously high quality care. People want knowledgeable and competent practitioners, but they also want open communication. People want to be heard, believed, informed. They want timely access to care and support. They want minimal wait times. They want good scheduling. They want to be connected to their care. They want reasonable costs. They want to be able to afford going to see their clinician. And I think importantly, to thinking about how we might think through policy and value, they want to have a focus on the whole person so that emotional health is recognized. And it's not only about sort of our hard outcomes, but also about things that reflect more of an entire person and how they experience their health moving forward. So in the collaborative, we brought together a large number of stakeholders representing patients, clinicians, academia, government, health systems, payers, professional associations, and worked together over the course of a year to talk through what a payment model might look like that had some of these sort of centering elements. And we ended up with a sort of full day retreat, creating a draft of this, which has been published subsequently. And we chose heart failure, well, partly because it was the American Heart Association, but because even within cardiovascular conditions, it's obviously one with high prevalence, costs, opportunity for improvement, and no current niche within current payment models. But I would think about this as sort of more illustrative, perhaps, of what chronic disease management could look like if supported by value-based payment. So the proposed payment model does not look so dissimilar in terms of some of the things that you heard from the prior speaker, where we needed to identify some key features. So how do you get into the model? How do you get out of the model? What is the payment approach? What kind of things are we going to measure? So I'll walk through these elements in turn. So the first thing in thinking about incenting care through value-based payment is a trade-off between specificity, so saying we have a very specific population we want to focus on, and sort of breadth. So ACOs take a very broad approach. Episode-based care that you just heard about before takes a pretty narrow approach, so one patient condition for one chunk of time. And here we went somewhere in the middle. we elected to choose a definable patient cohort, but then an extended length of time. So we wanted to start with patients who were either hospitalized or had an emergency department visit for stage C heart failure, and requiring that that was confirmed. So we weren't going to, pick up people who had a rule out of heart failure or something like that at admission, or a treating physician could refer somebody to the model. So someone with whom a physician had a relationship. And that both the patient and the clinician and the payer would have to agree that this patient fit the model, which seems reasonable. The most important part, maybe in concert with the payment approach, was really a focus on trying to shift the care delivery model. So we think about heart failure care obviously as being a chronic disease, but most of our payment models are focused on acute exacerbations. And so in this case, we wanted to focus on what it would mean to prevent those in the first place. And that very much dovetails with how we think about preventing readmissions, right? We prefer to prevent all admissions. The admission is just sort of a signal that there's someone who's at high risk for readmission. But lots of these elements would very much apply to readmissions, which is that care is provided in home or community-based settings whenever possible, and that this is fundamentally team-based care, including nurses, social workers, community health workers, and care coordinators, people who can help with all of the pieces that are not just about the heart failure itself, or maybe that dovetail with emotional health, with social needs, all of those things that really need to come together, but currently aren't supported in a fee-for-service model. And of course, a focus on high fidelity adherence to evidence-based guidelines through an appropriate data model. Now, the specifics of the payment approach could go one of two ways. You could go all in. So here's an annual or monthly payment with some downside risk. And you heard from the prior speaker that there's different ways you can sort of scale that risk based on people's readiness to assume risk. Hospitals can assume much more risk than some small clinics, for example. So you may have to think differently about when and how that downside risk comes to bear. The other way to do it would be a per member per month care management add-on without risk, either as a starting point or as sort of a bridge to a more fully global payment system. But the important thing here is the flexibility, that payment is not tied to being seated in a physician's office seeing a very specific clinician, but instead is tied to providing longitudinal care to keep patients out of the hospital, which is fundamentally the goal of most of these programs. Of course, we would need data sources. This grew out of some work that had come from Get With the Guidelines Heart Failure, which is an inpatient clinical registry. And we don't have outpatient good clinical data like that in most places. And so we realized that in order to be able to appropriately track recommendations and even to sort of push recommendations through something, a clinical registry that sat on top of EHRs would be something that would really enhance the likelihood of success. Claims data obviously helps us get hard events. Patient experience data and patient-reported outcomes are crucial because we need to understand how we're impacting not just those hard outcomes like death or rehospitalization, but also the sort of process by which we're making improvements in there, and frankly, how patients are feeling. And of course, recognizing that understanding social determinants of health is actually essential to being able to help patients manage their health. In quality measurement and evaluation, we prioritized data to support adherence to guidelines. As I mentioned, patient-reported outcomes, shared decision-making, and quality of life, measuring heart failure hospitalizations and mortality, and explicitly and specifically measuring equity to ensure that clinicians were incented to focus on their most disadvantaged patients where the inequities might be greatest, even if that would require, and perhaps because it would require, some innovative thinking. Of course, people don't stay in these models forever, so we had some built-in exit triggers. For example, if a patient moves and becomes attributed to a non-participating clinician, if a patient gets to end-stage heart failure and we need to think more about palliation or moving towards, VADs, inotropes, or transplant for the appropriate patient, recognizing that that then is not a good time to try to rely on a capitated payment. You don't want to disincent those sorts of discussions if needed. And of course, if a patient were to pass away. So in summary, value-based care is a tool. It's not a solution. It's just one of the things in our toolbox to try to change up how it is that we provide care, to reduce readmissions, to improve patient outcomes, and to make people healthier. Care can and should be built outside the hospital walls. It needs to be patient-centered. And I hope that our experience in value-based payment on the inpatient side means that we may be ready to think about how outpatient care could be even more powerful at achieving some of these goals. Value-based care should engender flexibility and whole person care. That's the special sauce, right? That's how you get innovation. It's not the up and down of the payment. It's not a percent bonus or a percent penalty per se. It's flexibility. That's what clinicians want, and that's where they engage in innovation. Now, tying that to financial bonuses and penalties may give it teeth, but penalties and bonuses alone without flexibility is unlikely to create the kind of change that we really hope to see in the long run. It could be primary care based or specialty care based. We didn't specify in this model who might participate. It should always require high fidelity adherence to guidelines and specifically reward innovations to improve outcomes as well as explicitly equity. Thank you very much. I look forward to hearing the rest of the talks and to hearing your questions in a little bit.
Thank you so much, Karen. What a spectacular overview, and I really like the way you were able to share your conceptual framing, which I greatly appreciated. We have the privilege now of having Colleen Booz-Dietrich, who is the director of the Continuity of Care program at the University of Kansas, and she has responsibility for ensuring sort of all aspects of transitional needs at KU, and has been working very hard on addressing patients who are very, very frequent flyers with whom we're all familiar. And so she's going to be presenting today on the instant replay of the multi-visit patient game plan. And thank you so much, Colleen, for presenting today.
Yes, thanks for the opportunity to be here. I assume you can see my slides okay. And let's go ahead and kick it off. So as Karen mentioned, I think some of the work that I will be sharing with you will take us right to the bedside with the patient. And we'll tell you a little bit about what we're doing to respond to our multi-visit patients here in our hospital. So this started for us as a collaborative with Vizient, and we had the opportunity to partner with Dr. Amy Botwell, who is the creator of these strategies and methodology. We started this in October of 2018, but a lot of it was very much behind the scenes until the spring of 2019 when we had some of our tools and resources in alignment. We started with a core operations team, so looking at various disciplines to come to the table to help us think about how we can respond differently to our patients who are having a higher than normal or expected readmission rate. When we started, we had 2 case management staff who were charged with helping us build this program and assess the needs of our patients. We now have 6 case management staff and a physician advisor who supports this work. The first step is really to look at who is an MVP, and for each hospital or health system, this definition looks a little bit different. For us, when we started, we were starting actually with 5 or more inpatient hospitalizations in a 12-month look back. We did this in part because of our staffing resources and our volume. We also scaled to only look at medicine service lines rather than all service lines in our health system. And we certainly still exclude admissions for chemo or radiation. This past summer, we did expand to look at 4 or more inpatient admissions in a 365-day period. We set this number for our criteria because we learned in our Vizient collaborative that 4 admissions in a 12-month period is considered to be a standard deviation over like the norm or the average for patients. So since we started our program flagging these patients in our system in October, we've identified 1,487 MVPs. 493 of those have since passed away during the course of being enrolled. We have 994 who are still active in our system that our team is following. And of those 994, 499 of those MVPs are now what we consider low volume, which is less than 3 admissions in the last 12 months. The reason why we focused here is we were also taught that 5% of your inpatients can account for up to 50% of your readmissions. And so when we ran our data, we were running at about 45%. So this seemed to be true for us in an area of opportunity. One of the things that really resonated with us about this work is that the patient presenting with this high of a volume really should be seen as a symptom, and no different than we treat all of the other clinical conditions that they present with. And MVPs have unmet needs that tend to be clinical, social, behavioral, and we've even added logistical to this. So the goals of our program are, one, to develop a reliable way for our health system to identify these patients, and then really to go to the bedside, talk to the patient, the family, the support system around that patient, and understand the driver of utilization. So why is this patient coming back to the hospital more than the same patient who has the same diagnoses, age, et cetera, but is staying out of the hospital? So our goal is really to implement a strategy to help slow the cycle. And with each patient, this looks a little bit differently. We created a daily report that our team receives that identifies new patients who now meet this criteria set. Our enrollment really is about going to the bedside, talking to the patient. We add a banner to their chart, and I'll talk to you a little bit about that tool here shortly. But that is the enrollment, if you will. And then we start to follow them every time they return to the hospital. We built some different documentation tools as well, which I'll also walk you through. And that has really helped us to both make the care team aware of the patient's high utilization, but also to help better address the unmet needs of these patients as a care team. When we first started going to the bedside and having these different kinds of conversations with the patient, we were taught to not look at the chart, just talk to the patient, go to the bedside, listen to the patient, hear their story, understand what is happening around them. How are they navigating their chronic disease, their community, their support system? What are we seeing that tends to be the driver? So this actual list here is under construction for us. This was our original list that we populated, and ED 911 is easier to access, is a big bucket. I think through discovery and working this program, I'd also say it might also be a default bucket for us. And so the challenge that we have for our team is we need to ask why 5 times. So why is the ED 911 easier to access? Is that because it's a quick way to get assurance of symptoms? Is it because that's the closest place they can get to? Is that because they've done that for 20 years and that has worked for them? And so it's really a habit, but there's alternate care pathways that would also work for them. And we can help to redirect that to more appropriate settings and level of care. Another key component of this work that is different than other work that we have done to date is the key to success is definitively linking the patient to the community resources. So I really believe the answer is in the community. And so identifying the patient's unmet need, as well as identifying the community resources, some of that can be internal within the health system, looking at alternate care pathways or clinic resources or roles within the health system that could be helpful, but also really looking at other resources in the community, agencies that maybe could follow that patient for longer and really wrap their arms around their social situation or behavioral needs that would help them to be successful. So we assign our team so that they follow the same patient every time they come back to the hospital. And so we get to build a rapport and individual relationships. We get to understand their baseline. We also get to understand their needs. And so it makes some of those follow-up conversations easier. And sometimes it does take a couple of assessments and touch points with that patient to have that aha moment of what we can do differently. But our challenge every time is what can we do differently? And we continue to try to implement new interventions for the patient to hopefully slow that cycle and really link them stronger to both their care team and the community resources. Another key part of this program is really to manage to achieve stability. So when our patients do return to the hospital, even if they haven't been in for a year, and we do have some patients who have fallen into that category, we want to learn what has worked for the patient and build off of that success. Leveraging the care coordination across the continuum to make sure that the patient is well supported, well informed about resources, and is able to achieve that success that they've had in terms of remaining in the community to manage their disease and get their needs met. Another important piece of that is what we call planning for the return. So we anticipate that the patient most likely would come back, and we plan for what to do next time. So we do this in a couple of different ways. We have a daily huddle as a MVP team to talk about our patients. We also have a weekly case review where we talk about patients and do some of this planning. And then we participate in the huddles with the inpatient team to also talk about what we can do differently for this patient. Some of the care alerts that I shared with you also are helpful to plan for the return and support that early discharge. So the banner that I'll walk you through now is actually designed so that when the patient hits the ED triage, we get an alert, which is a page. And that page goes to our team, and we have the opportunity then to go to the bedside in the ED, meet with the patient, the support system, and talk to the ED care team to see if there's something that we can do differently. Our banner also links to a patient care coordination note. And the advantage of this note is that it can be seen across the continuum. So our ambulatory providers, our ED providers, and inpatient can all see this note, which makes it very easy for, regardless of where the patient presents, to be able to pull up this information and learn a little bit more about them. We've also been able to design within this note a way for a refresh to occur when the patient represents so that we get an updated count of their ED visits and their admission. So we always have the most up-to-date information about their most recent utilization and what their driver is that we're attempting to address. We've also shifted recently to a storyboard alert. The advantage of this particular alert is that it can be easily viewed by all providers, all disciplines, without us having to work too hard. So the banner we had to populate in key areas where we knew docs and nursing went into the chart to be able to make that alert work. The storyboard is a default alert within Epic, and so everybody sees this on their homepage of the patient, and that makes it a little bit easier to grab that information when the patient presents to any setting. We report our outcomes to our advisory team and our executives on a monthly basis. And I wanted to show this original format that we started using, because especially early on, you have to get to critical mass to really impact your overall readmission performance as a hospital or health system. But when we looked from a month-to-month cadence of how we were doing, we were able to look at the percent reduction in MVP discharges starting in a particular month to as far as we had been working the program. So this particular snapshot shows the data from when we started in October of 2019 to I believe maybe April, it shows on your screen for that data. And so we had a 49% reduction in MVP discharges in that period of time, and then a 40% reduction in MVP readmissions for patients that were meeting our criteria in the medicine service line. And I think that this format's important because when you get started, it's nice to see those small wins over time and measure that impact. We've shifted to this format now, and this really tries to look at apples to apples in terms of success of individuals being in this program over time. So we've been doing this for a while. We're continuing to evolve and tweak it, but we want to understand kind of that pre-utilization of the patients prior to being followed by our team, and then looking at their utilization over time. The other thing that I mentioned, we had a discovery recently that when we're doing our daily huddle and assigning new admissions, we were getting a little nervous because we had everybody hovering at about 200 for their average caseload, and we're still having new admits meet that 4+ criteria, and it was hard to figure out who to assign them to. Then we had a discovery that about half of everybody's caseload is now a low volume, so they're not coming in with a high amount of frequency, which is a very different lift to follow. We still do keep the banner on those patients, and we still do go to the bedside to meet with them. A lot of that is having a good touch point to see what's working, so we can learn from that as well as continue to support the patient as their needs may change. I always think it's important to talk about the patient and the success stories. When we started early on and went to the bedside and tackled some of this work and tried to figure out, what could we do differently? We had lots of people volunteering patients that maybe could use our resources and support. And these are just a couple of different examples of patients that we were tagged early on to follow as we were getting our legs underneath us with this program. So you can see there's several different diagnoses called out here. I think one of the telling things for me as we look at the success stories is you're seeing a sickle cell patient who had 39 visits in a 12-month period of time, 27 inpatient and 12 ED discharges. We found that the underlying driver was the ED was easier, and there was some pain-seeking behaviors as well. It took us several interventions to do something different with the clinic coordination, the inpatient team, and the ED. And we also linked them to some behavioral health resources and gave them an alternate care pathway for infusion room treatments. We were able to support a patient who was coming in every 3 weeks, 2 to 3 weeks or so, to stay in the community for 56 days out of the hospital, which was such a huge win. The patient was happy. He was coming back and telling us what he was doing with his life now that he wasn't in the hospital as much. This patient down below who came in pretty intoxicated with a fair amount of frequency. Sometimes he would come in the same day we discharged him, intoxicated again. And he was actually our first patient that we did a true kind of bedside intervention with. His underlying driver was depression and isolation, and his support system and the environment that he was living in really wasn't one that was allowing him to be successful. And so he was utilizing drugs and alcohol to manage his symptoms. In that 12-month utilization, he had 31 visits, 24 inpatient and 7 ED discharges by the time we got involved. The first time we met with him, there was some discovery, but some resistance. But we went from 4 days out of the hospital to 6 days out of the hospital. And then we went a little bit longer. We also were able to coordinate an inpatient stay on our psych unit to be able to address the mental health needs, which also allowed for 30 days sobriety. Our team even went over and had a celebration with him to really make sure that we were giving him some good support around that success. But one of the key things that we did for him at the very beginning was we learned that he had a sobriety coach in the community. And we also learned that the sobriety coach could never meet with him because he was always in our hospital. And so we said, you know what, why don't we just have the sobriety coach come to the bedside? And so we did that. We coordinated the conversation. They built that relationship at the bedside before the patient discharged. That person had a plan to meet with them shortly thereafter. His discharge, and that individual really worked with him on the community resources to help him navigate and be successful. So he was able to then achieve even longer than what it says now, but at the time we took a look at this snapshot, it was 196 days out of the hospital. And the success that we felt when we did have a return to the hospital and had the opportunity to see him again, he shared with us how much he likes being sober and what an accomplishment that was for him to be able to achieve. So I think it's really good, as Karen said, to tie it back to the patient. And this is what we're here for, and understanding their needs, really meeting them where they're at and helping them navigate differently is what this program is about. And where I think we've been able to see some success over time. So I know it's a lot of information in a short amount of time, and I'd be happy to email anybody if you want to do a deeper dive on this work or look further at those tools. Thanks again for allowing me to be here today.
Thanks so much. And it's very inspiring to see how KU has invested in the personnel to really help some of these higher need patients. And so congratulations on leading that effort. And I hope you'll stick around for questions at the end. It's my incredible pleasure to introduce really one of my oldest friends, just because he's such an old guy, but really somebody I've known for decades, Harlan Krumholtz, who served as a mentor when I was starting down this pathway and who really embraced the idea of thinking creatively and innovatively about how to tackle some of the challenges in healthcare. And throughout his career, he has accomplished amazing impacts in the way we deliver healthcare, from really embracing and challenging the whole country to think about reducing the time to acute reperfusion for myocardial infarction, to now serving as a contractor for Medicare, really thinking about how can we measure and help improve the value and quality of healthcare. He's led numerous efforts and numerous projects, and he's had this idea that many of us are starting to sort of get very inspired, but thinking from a researcher about a different way to explain or understand or even begin to understand why patients come back so quickly after being discharged from getting such great care in the hospital. So he'll be talking about post-hospital syndrome. And Harlan, thank you so much for taking the time to present today.
Yeah, thanks so much, John. It's a real pleasure to be here. And to those of you in Kansas City, you should know that having John Spertus as a local resource is just extraordinary. I just pay him back the compliment of saying that, as an innovator and leader and someone who's made substantive change and always has eye on the ball of what's best for patients, there's really no one I can think of that has done more than John has around there. And Kansas City area is very fortunate to have John there. Also, I've really appreciated listening to Tony and Karen and Colleen and Karen. Thanks for the shout out with the reference. And it's been my pleasure to learn from them and to sort of see what they're doing. What I decided to do was, in my 14 minutes that I was giving, I'm going to riff a little bit because I'm going to broaden out just a bit, because I was going to talk just about post-hospital syndrome, but listening to the others has sort of stimulated me to think a little bit more broadly about readmission. I just want to share some quick ideas with you. So I was trained in some of the best hospitals, and do you know how many lectures I got on this issue of readmission? Do you know how much attention was paid to it? You know how many textbook chapters there were that I was directed to or papers around it? Zero. You know the culture I was brought up in? Get people out of the hospital, reduce your service. I'm embarrassed to say that, when I reflect back on my residency, and I was with some tremendous people, and many of my attendings were great humanitarians, but the mindset was get people out of the hospital, and the amount of time we spent, the attention on the transition home, the thinking about what the experience might have been for the patients was minimal, just minimal. And when people would show back up, it would be, we would say disrespectful things like you bounce back or frequent flyers, or they would be labeled in ways. And often they would, the idea would be that, there was something going on with them, not us. We couldn't be us. We couldn't be something we did, even though we paid really virtually zero attention. Then as I became an attending, as I went through fellowship and became an attending, it was sort of normative like that. And it was really, I started working with the peer review organization in Connecticut and started thinking about patient outcomes and accountability around it. And we sort of began talking about this issue of people coming back to the hospital. And there had been an article in 1981 by a guy named Earl Steinberg and Jerry Anderson at that time from Hopkins, that it sort of talked about readmission, been in the New England Journal of Medicine, but it was more about healthcare utilization. It was a great piece, but didn't really gain traction. And we started saying, well, let's take a look at this. And we took a look at a group of patients who had heart failure, and realized that within 6 months after being discharged from the hospital, half of them had been readmitted. And that article, which became highly cited, was just a basic descriptive article, sort of started me on a journey to start thinking about what's this like for patients, and what's the ultimate cause, and what are the implications of this? Because as I started thinking about this group that went home from the hospital, I couldn't think of another group that was as at high a risk. I mean, if I was going out in the community and I was trying to find a group of people who I could predict with pretty certainty, 1 out of 2 of them were going to be in the hospital within the next 6 months, I'm sort of hard pressed to find that group. But this is a group that was a very high risk. And when you started looking as close as 30 days, you were getting to 1 in 4, 1 in 5 of them would be back in the hospital. And that doesn't count people who end up in the emergency department. We actually developed some measures that are talking about days of acute care, which include emergency department. Start adding that together, and you really get a very large number of people. And as we started looking at this, we realized that there was a reason that, at least within the healthcare system, that there was this systematic indifference to this, because you know what? Readmissions were big business because there was a positive feedback on the business side of healthcare. And I hate to say it like that because we're all professionals and we want the best for our patients. But the truth is, there is an underlying business model here. And the business model is when they came back, we got paid again. You know, we doctors got paid again. The health systems got paid again. In a fee-for-service system, every one of those readmissions was a revenue opportunity. And that's terrible to say out loud. But I heard people when I went to administrators, not just, you know, anywhere around the country, that the concern that reducing readmissions might affect the bottom line. Believe it or not, people would actually say that out loud. And so, you know, our group began thinking about what could we do about this? Well, we started publishing a lot of papers, trying to bring attention to it, understanding it, recognizing that people were coming back for a whole range of different problems, and trying to get to the root cause of it. We ran quality improvement programs. There was a time when we were working with CMS, I don't know, this was about maybe 15 years ago. We had been working with them about 20 years ago on process measures. And we sort of felt that we'd exhausted the process measures, and that the process measures, things like, are they getting aspirin, beta blockers, how fast are patients being treated, we're only capturing a very small amount of the overall quality that was being provided, and that we needed to start moving towards outcomes. So what were the mortality rates? And CMS came to us, at our group, and suggested that maybe another measure we should look at is total cost of care. That might be something that could be publicly reported. And we sort of were reluctant to enter this area of cost, because high cost still could mean high value. I mean, just because you're spending more doesn't necessarily mean it was the wrong thing. And if there's some hospitals that are spending more and getting better outcomes, then you wouldn't want to just tell them, well, you need to minimize the cost. We need to be able to understand the value. So what we proposed back to CMS was, well, what if we started measuring readmission? What if we developed a measure that could then be publicly reported, and people could start to learn what the readmission rates were? And so they agreed, and we embarked on an effort to do these readmission measures that ultimately resulted in a big little bit of fanfare, and Mike Levitt sort of being in a public forum, sort of announcing that CMS was going to start doing this. One of the interesting things we learned in doing these readmission measures was that although we could predict mortality pretty well, so we could risk adjust mortality pretty well, almost all those predictors, all the factors about patients that predicted mortality were much weaker, if they existed at all, in predicting readmission. And some people started saying, well, you shouldn't have a readmission measure because your risk adjustment's not strong. But for us, we thought it was an indicator that the factors that were influencing whether people came back to the hospital were less about the patient and the severity of their disease, and probably more about the context of their lives, the support that they were getting, the kind of handoffs and trade-offs, a lot of things that we weren't measuring, because it was a lot about quality, a lot about the way the system was supporting the individual, a lot about what was there to enable the transition from hospital to home to go smoothly. So with that, you know, our group, we ended up doing studies on a wide variety of interventions. We did one very centralized intervention at our place where it was very hands-on. For a small number of patients, we were able to reduce readmission rates by about 44%. We published that. It was a small study. We ended up doing a large study where we provided information to practices, that sort of telemonitoring study that actually failed. And what I think I learned in that process was that there's lots of points of failure along the line, and there's so much variation among clinical practices. And even when you tell the practices, you know, here are some things you might want to do if the weight goes up, if their health status declines, or this, that, there's just a lot of complexity that has made it difficult for people to sort of start implement these systems in ways that are consistent. And made me think a lot more about the need for centralized approaches. But a lot of the interventions were about, how do you catch people when they leave? How do you help them in that transition and to get home? But I was always perplexed by this fact that why is it that when people leave the hospital, they're susceptible to a whole range of problems that seem often unrelated to the reason that they were admitted in the first place? And why is it so hard for us to make progress by just trying to catch them better, by trying to create the transitions in the outpatient side? Well, aside from that complexity, is there something else here that's going on? And we started investigating this, and there had been a wide range of studies that had focused on this issue of allostatic load, which was really sort of repetitive stress and what the impact that was on physiologic systems. There was a guy named Bruce McCowan who ultimately became a collaborator, recently passed away, but he was at Rockefeller, and he had this animal model where he would take these rats and he would put them in a position where there was a lot of noise, they couldn't get sleep, the nutrition was poor, a lot of unexpected things were happening all the time. Anyway, we started looking at that model and saying, like, that sounds a lot about like what people experience when they're hospitalized. Started doing a little bit of research and saying, like, yeah, sleep deprivation is really common for people in the hospital. Malnutrition is very common for people in the hospital. There's, of course, a lot of unexpected events. People come in, there's a lot of stressors. I can go down a whole list, and any of you who have had experience of people in the hospital know that it's a bit of a stress test. And when you looked at these both in animal and human studies, when you put people under these conditions, all they're hematologic, they're immunologic, they're metabolic. I mean, every different system in the body becomes deranged and in some ways malfunctioning for some period of time. Even when you take healthy college students who are robust and physically fit, and you put them in conditions that sound very similar to what our patients are under, irrespective of their underlying conditions, then they exhibit a lot of these physiologic derangements. And I'm glad to share with you articles that we've written about this, but it got me thinking that, and we codified this in a paper written in the New England Journal around, I called it post-hospital syndrome. I was saying, I think if we're going to make progress, we have to both work on ensuring that people are stronger, better able to manage when they leave the hospital. And we have to be able to also support them in the outpatient area and in their transition to home, and recognizing the kind of stresses that they're going to be under in that situation. So I think I'm glad that we're embracing this idea of thinking about readmission. Believe it or not, some of my colleagues have actually said to me, readmissions is an artificial endpoint. Patients don't care about readmission. I mean, really, I've heard that repetitively from some sectors in my field. And I'm saying, like, well, tell me which patient, if it were preventable readmission, would want to come back to the hospital after having already had a taste of it within the last month. I mean, I really have yet to encounter someone like that. So I think having us focus on readmission is really about trying to focus on what's the world like when you see through the patient's eyes, and how do we alleviate the kind of anxiety they have when they go home? How can we support them? And how can we make sure they're stronger when they leave the hospital? Not so sleep deprived, malnourished, stressed to the max. And how are they better prepared to go home? So in the end, I just want to say, and I know we're going to transition to the discussion now, is that I think that this thing, for example, what Karen was talking about and Tony, the idea that we need to create the incentives, we need to create the imperatives for this. We need to reward the kind of interventions that make it smoother for people from hospital to home. By the way, for them, there is no distinction between hospital and home in the sense that they're experiencing the episode of an illness. That episode traverses venues. It's artificial for us to be thinking about hospital and home. We need to be thinking about how they're experiencing acute illness and recovery, and how we're supportive throughout that entire spectrum, helping them to get the best possible outcome. So we need to make sure that there's nothing that's, you're not penalized, at least, for doing the right thing. And at best, you're actually rewarded within the healthcare system for paying attention and trying to have this patient-centric idea. We need to strengthen the outpatient side so we catch people better. And we need to, I believe, focus intently on what are the kind of things that can happen during the hospitalization that put people in a better position when it's time for them to make the transition to go home. They're stronger, better, able to manage. So thank you very much for your attention.
Thank you very much. Now it's my privilege to introduce Christina Pacheco, who is one of the co-leads of this QVIC initiative, and she's going to field questions. Anybody who has questions, you can either unmute, but also please feel free to put into the chat, and we can read some of those questions. And basically, I could just sit and listen to Karen and Tony and Harlan and Khalid just, banter among themselves. But I know, we've had almost 70 people floating in and out today. And so those who have stayed patiently to ask their questions, please do so. And Christina, it's all yours now.
Yes, thank you. And thank you to our presenters, Dr. Sun, Dr. Joint Maddox, Colleen Booth, and Dr. Krumholtz. Thank you again for excellent presentations. Is checking the chat box. I know Stacy had a question that Colleen answered. So if you have any questions for our speakers, please feel free to unmute, or if you are more comfortable providing them in the chat box, I'm happy to read them for you.
I have a question for Karen, just to say that I thought that was a terrific presentation and was very attentive to all the kind of key determinants. And maybe I missed, but so now where do you stand? How do we scale this out? How do we embed these concepts and ideas that you sort of so nicely outlined? Because one of, I think, the challenges I've seen is like, how do we get people to embrace these sort of new strategies?
Yeah, I completely agree. And I think we're at a sort of a point in time where the implementation is the question. So, you and your group and others did a lot of really heavy lifting to get hospital value-based payment, across a range of things to be sort of what we do, right? It's sort of the norm. The outpatient side has been a lot trickier. It's a lot more diffuse. It's just a trickier space to try to engage people in value-based payment, but I think there's so much potential there. And it will probably require multi-stakeholder engagement, because the last thing you want to do is start to throw these things at outpatient practices 74 different ways from a whole bunch of different payers. So I think that in order to really change how we think about sort of chronic disease management, which dovetails with exactly what you said around when people leave the hospital having all this vulnerability, I think it's going to probably require specific attention to multi-payer engagement around trying these models, and having people at the table designing them who can very much speak to the social determinants and equity piece. Because I think that's something, if we don't put that in these outpatient conversations, as Colleen outlined, we're just not going to move the needle.
And should these be competencies in our field? I mean, one of the things I've seen is that, still, I told you, like when I went through, I can't remember one lecture in my entire training period that sort of focused on this. And if people sort of talked about it, like you'd think, well, this isn't medicine. I don't know what this is, right? It's like something else. But in fact, it is medicine, and we need to be able to sort of help people understand that these are competencies that if you're taking care of patients, both those with acute who need to recover, and particularly those with chronic conditions, these are core competencies. I mean, if you can't speak the talk that you gave, right? If people can't really understand what you've said and can even teach back, those central concepts, then we're failing. And so kind of changing the culture and getting people to think about like what really represents the hard work that needs to be done to get good outcomes. It's not just the sexy procedures. It's actually the hard work of helping to manage individuals and their challenges.
Yeah, I couldn't agree more. And I think it also makes a good case for team-based care. And, I think this came up in some of the other presentations too, that we don't need to make sure that every person can do all of those pieces, but you can't think you can do any one of those pieces and have that be enough for a patient. That's not how this stuff works. And so, I do think that medical schools are shifting to some degree, but they're still pretty locked into people needing an awful lot of biochem. And trying to figure out how to balance that out with thinking about these sort of broader lessons in public health and in health more generally. So yeah,
I'd love to ask,
Karen and Harlan, there's a a lot of desire to think innovatively about how to deliver more patients that are more efficient care, team-based care, et cetera. But we don't have a financial reimbursement model that allows one to invest in the infrastructure. I mean, you want to start collecting PROs, you got to get an EPIC program or the program, the KCCQ into EPIC, and that takes resources. And you don't get paid for collecting that data. So what's to incentivize you to have somebody at the front desk make sure that they work? How are you going to support the time for multidisciplinary team-based care? I mean, I think what KU's investing in is remarkable because they're hiring a team of social workers to invest a lot in addressing and individualizing each patient's need, but that comes at great cost. And I suspect that's just a loss leader for them because they're not making up. They currently are probably losing money on a few of those, fewer readmissions. And so how do we think about sort of incentivizing and rewarding the creative strategies? The docs, the nurses, the people who are caring for these patients probably have a myriad of great ideas, but can't get the investment administrative support to pursue them. And even if they're successful, the hospital could lose money because, again, some hospitals make more money on the readmission than the penalties. And so, what is it going to take to sort of allow us to start to do the creative steps needed to address these problems? And I'll just add another layer. If you want to address the social determinants of health, it's even more difficult because that's really outside your walls. We have a very novel program that's part of our heart failure readmission strategy where there's an organization that has contracted with all the community-based organizations to do an in-home assessment and actually do a very personal handoff to Meals on Wheels, to transportation services, to MedRec, to whatever they need to help address the social determinants of health. But it's ultimately going to cost money, and how is the hospital going to recoup that investment if they think that creatively to invest in those kinds of services?
Yeah, I'd actually be interested in Tony's thoughts about this as someone who pays for it, but I would say it requires moving toward population health. It requires hospitals being part of a broader effort to keep people healthy and well and out of the hospital. And as Harlan said, that's a weird thing to ask a hospital to do. We found the same thing in some qualitative work we did, that hospital CEOs were like, we ran the math. We know how much we get paid for readmissions. So it's really shifting a philosophy as opposed to sort of just changing a little bit of payment. And that's not easy. You see some ACOs have moved meaningfully in that direction, particularly physician-based ACOs. We see integrated delivery systems, Kaiser, places like that operate with different philosophies, but ultimately it's got to be about moving toward population health. And, one place that is interesting to do that is Medicare Advantage, which is sort of a capitated program already, right? And you see a lot of experimentation within the MA world around, addressing social determinants, around doing things that we can't do in a sort of old-fashioned fee-for-service system. So I'd punt that along to see if Tony has thoughts on that piece.
Yeah, so I actually want to think of it a little bit more optimistically. We do have models now. We need to think about how to utilize some of those existing models and make it faster. And so I know at times we continue to say, yeah, only if, but instead, how about now? How are we maximizing the existing models of, for example, here in Kansas City, how do we really accelerate the multi-payer pilot we already have built out under CPC Plus? How do we learn from the ACO experience in various health systems that they have begun, okay? And again, this is public now, but for example, John's Institution of St. Luke's, they have both commercial and Medicare Advantage ACO arrangement with United Healthcare. They're working diligently with us on trying to identify those. Those payer and provider collaboration does exist, and how to really hone in on share savings and moving toward risk faster, okay? And we have to drive it from an outpatient perspective. Karen, I can't agree with you more. Doing it from an inpatient is is, to me, is just not as productive, and you're fighting against a very entrenched mindset that has been very difficult to change. Don't get me wrong. I think some of the great work that we're seeing, in particular, even in Colleen's work they're doing, is terrific, okay, on how to begin to think about this as a community of health and managing that population. And by the way, this is very hard work, as Harlan already pointed out. This is not easy. If it's easy, already it's solved, right? Some of the work from the National Academy of Medicine, they have talked about high needs, high costs for some time. Taking those bits and pieces of those key principles, I think it was Melinda Abrams who really has insightfully talked about it from Commonwealth, those principles, right? How to drive that, right? When we're talking about identifying those subgroups, not just by disease, but the heart failure that is isolated, that doesn't have anybody take care of them. That's a key subgroup, all right? How do we move from that to home-based care based around the patient's social needs, based on their behaviors, all right, and make it easy for patients to do those things instead of make it harder? And guess what? Then 911 would be the easiest button to push, okay? So I do think we have those. Again, as you can tell, I'm a glass half full person. So I think we have those in place. We really have to really push and elbow our way into getting those solutions.
Can I just ask, I wanted to wonder what Colleen thinks about this idea about scaling. I was so impressed, Colleen, you have such great stories and interventions. I mean, but also reflection of those interventions about those patients that you've helped. How do you think about how we can spread the magic that you put together to make those things work?
Well, I do think it's a shift in culture, and that's a heavy lift. And so I think that's what, our team is trying to do in partnership with the docs and the ambulatory clinic and the other roles in the community is really shift that. And I would add, I think one of the things we said early on, we're part of this problem for our patients, and how do we develop things to make alternate options easier? So that's kind of what we're trying to do with some of our individual interventions, is to create those pathways that are different for the patient that become then easier for them than utilizing the ED or that inpatient setting. And so it is hard, once they're admitted, they're already admitted. And so the work looks a little bit differently than when you position yourself to try to anticipate for that return and what do they need. That we can support in the community. So I think some of our lessons learned is leveraging even our own internal resources. So about 40% of our patients are followed by our primary care group. And, that's key, because we have chronic case managers and we have other resources, that we can link the patient to. And we've started to have huddles on those patients in the ambulatory setting, not in the inpatient setting. So we're talking about them when they're out in the community and in that clinic setting. So I don't know that I have a magic wand, but I think it is a culture change for all of us. And I do think that when I say the answers in the community, I think that we, especially when they present to the ED and the inpatient, need to think beyond that discharge plan to really effectively link them to a path for wellness, or at least being able to navigate differently, their disease or their vulnerability in the community. So I think those are some of our lessons learned on what we think is working. And we're just going to continue to chip away by community resource and patient care plan to hopefully, make a difference.
I just think if the framing were that, I mean, I know people say this a lot, but I'll just say it also. Like, if the framing were that what you had was a therapy, a pill, a procedure, and you were getting that kind of result as it would be reprehensible not to provide it and to institute it, right? That the kind of results that you're getting, and yet because it's a complex intervention, it ends up being understood in a different way. And we need to be able to celebrate the victories, the advances, and then be able to frame it in a way that, this is almost like an effective therapy that needs to be made widely available to people, even
Right.
though it's a complex intervention.
Right. And I will say when I went to the hospitalist group to talk about this program, I've never been more well received at a physician meeting than when we talked about this work. People were raising their hand for patients that they needed help with. And I think that my aha moment is that we all know we need to do something different and we need each other to do that. The doc's looking at it very much from a clinical standpoint. And how do we pair that with the other perspectives that we need in that interdisciplinary team and the community resources to help us make an impact. I tell my team sometimes, if the doc knew the answer, they would have done it 10 admissions ago if there was like a pill that, would have solved this problem. It's complex. And so it does take a lot of pretty intense conversations and discussions around what the needs of the patient are to start getting innovative about solutions for that individual. And so that's a lot of what I think we're trying to do. But I think the readiness of the docs, I've been pleasantly surprised with. And I hope that is an indication that the culture is shifting.
Thank you so much again to all of our speakers. To be respectful of everyone's time, I want to make sure to invite you to next month's forum. The topic is isms, phobias, and microaggressions in healthcare. That will be held on April 15th, which is a Thursday at 3 o'clock. So please visit our website at kcqvic.org to register for that one. Thank you again, everyone, for joining us, and thank you again to our speakers.